Hey everyone, today we're going to be wrapping up the ICD-10-CM coding guidelines for 2021. I love this series so much because it has helped so many people understand some of the guidelines or just help them instead of just reading them through themselves. And there's actually a lot of instructors and people that are teaching coding that have reached out to me and said that they found this very helpful for their students as well. And now that the series is done, I'm actually going to convert it into a course for my website. And those of you that are paid members to the channel will have access to that course and can earn CEUs for that. Because it's about 300 minutes long, I'm going to apply for about 5 CEUs. So keep an eye out in the community tab because I will be posting that there for all of the paid members to access when I get approval. If you're not a paid member, don't worry, you can still get all of the content for free. It's just that I get a little bit extra for the paid members. They can get some free CEU offerings. I do have, I think, 1 or 2 already up. So check that community tab because I do post some paid member only posts that include the links to those CEU courses for the paid members. If you haven't joined yet and would like to join, there are different tiers of membership that you can join for as little as $1.99 a month, and it helps support me and the channel and me being able to provide more content. Speaking of more content, let's get into the last of the ICD-10-CM coding guidelines. All right, so section 3 is reporting additional diagnoses, and these are the general rules for other or additional diagnoses. For reporting purposes, the definition of other diagnoses is interpreted as additional conditions that affect patient care in terms of requiring either clinical evaluation, therapeutic treatment. It's going to extend their hospital stay. They have to do additional diagnostics. There's going to be increased nursing care or monitoring, which means more nurses are going to have to take care of them. The UHDDS item 11B defines other conditions as all conditions that coexist at a time of an admission that develop subsequently or that affect the treatment received and or the length of stay. So that means maybe the patient had to stay extra or they needed extra care because of these additional conditions that coexisted. Diagnoses that relate to an earlier episode that have no bearing on the current hospital stay are to be excluded. So it has to be something that impacts that specific hospital stay. The definitions apply to inpatients. So again, facility inpatients in acute care, short-term, long care term, and psychiatric hospital settings. So not your office visits, not your urgent cares, anything where the patient isn't formally admitted to the hospital. The definitions are used by acute care short-term hospitals to report inpatient data elements in a standardized manner. And then it says the data elements and their definitions can be found in the Federal Register. I'm going to have to do a whole separate video on the Federal Register because that is a beast. Since that time, the application of the UHDDS definitions have been expanded to include all non-outpatient settings, acute care, short-term, long-term care, and psychiatric hospitals, home health agencies, et cetera, et cetera. So everything that's not an outpatient office type of setting. But it also does apply to hospice services in all levels of care. The following guidelines are applied in designated other diagnoses. So again, things that are going to impact how much care they're getting treated with when neither the alphabetic index nor the tabular list provide direction. So again, additional diagnoses and things. The listing of the diagnoses on the patient's record is the responsibility of the attending provider. So first off, previous condition. If the provider has included a diagnosis in the final diagnostic statement, such as a discharge summary or face sheet, it should ordinarily be coded. Some providers include the diagnostic statement resolved conditions or diagnoses and status post procedures from previous admissions that have no bearing on the current stay. Such conditions are not to be reported and are coded only if required by the hospital's policy. However, history codes, so maybe the patient has a history of cancer or anything from Z80 through Z87, those may be used as secondary codes if the historical condition or the family history of that condition, so maybe a family history of cancer or heart disease, if that has some sort of impact on their current care that they're receiving. Abnormal findings. So patient has an abnormal lab, abnormal x-ray, abnormal diagnostic test results. Those are not reported and coded unless the provider indicates there's some sort of clinical significance to them. If the findings are outside of the normal range and the attending provider has ordered other tests to evaluate the condition or prescribe treatment, it is appropriate to ask the provider whether the abnormal findings should be added. Please note this differs from the coding practices in the outpatient outpatient setting, where we do code for diagnostic tests that have been interpreted by the provider. Uncertain diagnoses: if the diagnosis documented at the time of discharge is qualified as probable, suspected, likely, questionable, possible, or still to be ruled out, compatible with, consistent with, or any other similar terms indicating uncertainty, code the condition as if it existed or was established. And again, this is inpatient guidelines, not your office outpatient. The basis for these guidelines are the diagnostic workup, arrangements for further workup, and observation and initial therapeutic approach that may correspond most closely with the established diagnosis. Essentially because in the inpatient setting, they're going to work them up exactly the same as they would if they were suspecting that they had that condition. And again, it's just a reminder, this is applicable to inpatient admissions. Section 4 is your diagnostic coding and reporting guidelines for outpatient services. And it says here that first and foremost, those Section 1 guidelines, which are your general coding guidelines, as well as the ones of the chapter-specific guidelines, also are applied to office and outpatient services. Information about the use of certain abbreviations, punctuation symbols, etc., those are found in your Section 1. We kind of already covered those, so we're going to skip over that. The UHDDS definition of principal diagnosis does not apply to hospital-based outpatient services. That principal diagnosis concept is for inpatient facility services. Coding guidelines for inconclusive diagnoses, probable, suspected, ruled out. Those were developed for inpatient reporting, so we do not report those for our outpatient provider services. Selection of a first listed condition. So in the outpatient setting, the term first listed diagnosis is used instead of the term principal diagnosis. In determining the first listed diagnosis, the coding conventions of ICD-10-CM as well as the general and disease-specific guidelines take precedence over the outpatient guidelines. Diagnoses often are not established at the time of the initial encounter or visit. So oftentimes, for example, you go to your family doctor with stomach pain. They don't know what's wrong until they send you out somewhere else to go get ultrasounds or blood work or whatever. The most critical rule involves beginning the search for the correct code assignment through the alphabetic index. We always start at the alphabetic index. You can't just go and start looking for codes in the tabular list. You have to, because of the ICD-10-CM coding guidelines, start in the alphabetic index. So outpatient surgery, when a patient presents for outpatient surgery, so same-day surgery, we code the reason for the surgery as the first listed diagnosis. So for example, the patient might be having same-day surgery for carpal tunnel repair. In that case, our first listed diagnosis would be carpal tunnel. And we list that even if the surgery wasn't performed due to a contraindication. Observation stay. When a patient is admitted for observation for a medical condition, we assign a code for the medical condition as the first listed diagnosis. When a patient presents for outpatient surgery and develops complications requiring admission to observation, code the reason for the surgery as the first reported diagnosis because that was the reason for the encounter, and then we follow it with the codes for the complications that the patient had as secondary diagnoses. Codes from A00.0 through T88.9 and Z00 through Z99. The appropriate codes from those series must be used to identify diagnoses, symptoms, conditions, problems, complaints, or other reasons for the encounter or visit. Accurate reporting of ICD-10-CM diagnosis codes. For accurate reporting of ICD-10-CM diagnosis codes, the documentation should describe the patient's condition using terminology which includes specific diagnoses as well as symptoms, problems, or reasons for the encounter. There are ICD-10-CM codes that can describe any of those three. Describe the symptoms and signs. So codes that describe symptoms and signs as opposed to diagnoses are acceptable when we don't have that confirmed diagnosis. Going back to the stomach pain. If we have that visit that day, the patient says they're having stomach pain, we can just assign stomach pain as that sign or symptom because we don't know exactly what that is yet. Now maybe later on, maybe the next day they're going to go for an ultrasound, but at the time of that encounter we don't know, so we just use stomach pain. Laboratory findings not elsewhere classified, which are codes R00 through R99, may contain a lot of those codes, but not all of them for the symptoms. Encounters for circumstances other than a disease or injury. So ICD-10-CM provides codes to deal with encounters for circumstances other than a disease or injury. So there's what is often referred to as the zoo code, Z00, and those are your preventative care, like you're coming in for your annual physical type codes. So there's a lot of those from the Z00 through Z99, which are the status codes. And those are provided to deal with occasions and circumstances when we're not treating a disease or an injury or some sort of complaint or problem, but there is a reason for that encounter, oftentimes things like maybe preventative services or screening or something like that. Level of detail in encoding, ICD-10-CM codes, you always have to go out to the furthest extension of those characters, maybe 3, 4, 5, 6, 7. Some of them you only need 3, some of them you need 7, and anywhere in between there. So codes are comprised of that many different characters depending on what codes are. Those first 3 digits are referred to as the category, and they may be further subdivided into 4th, 5th, 6th, or 7th. So those 4th would be a subcategory. You are required to use the full number of characters, and again, if you have something that needs a 7th character extension, like an A for initial, then you would have to, if there's not enough characters, you have to fill in with that placeholder X that we talked about. ICD-10-CM code for the diagnosis, condition, problem, or other reason for encounter visit. List the first ICD-10-CM code for the diagnosis, condition, problem, or other reason for encounter visit shown in the medical record that is chiefly responsible for the services that were provided. List additional codes that describe any coexisting conditions. In some cases, the first listed diagnosis may be a symptom when that diagnosis has not been confirmed by the provider. Uncertain diagnosis. So we, in the outpatient setting, do not code probable, suspected, questionable, rule out, compatible with, consistent with, working diagnosis, or anything else that has similar terms indicating uncertainty. Those may be acceptable in the inpatient setting. They are not in the provider outpatient setting. We would rather instead code to the highest degree of certainty of what we know, or we might use those signs and symptoms, or if there was an abnormal test result, as that reason for that visit. Chronic diseases. So chronic diseases treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care for those conditions. We code all documented conditions that coexist. So we code all the conditions that coexist at the time of that encounter visit and that require or impact patient care or treatment or management. We do not code conditions that no longer exist, that they've, maybe a patient had breast cancer and now they've had a mastectomy and they've been deemed to no longer have cancer. Then we would use a history code for that, like it's saying here. However, history codes may be used as secondary if it may impact something. But in that case, we would no longer code it as an active condition if it's no longer receiving any kind of active treatment or has been eradicated. Patients receiving diagnostic services only. So for patients receiving diagnostic services only during an encounter or visit, we sequence first the diagnosis, condition, problem, or other reason for the encounter visit shown in the medical record to be chiefly responsible for the outpatient services provided during the encounter or visit. Codes for other diagnoses, such as chronic conditions, may be sequenced as additional diagnoses because they may impact the patient's care, or the provider may just be assessing to make sure that they are stable or that they're following up with the correct providers. So for encounters for routine lab or radiology testing in the absence of signs, symptoms, or associated diagnoses, we assign ZO1.89, which is an encounter for other specified special examinations. If routine testing is performed during the same encounter as a test to evaluate a sign, symptom, or diagnosis, it is appropriate to assign both the Z code and the code describing the reason for the non-routine test. For outpatient encounters for diagnostic tests that have not been interpreted by a physician and the final report is available at the time of coding, we code any confirmed or definitive diagnoses documented in the interpretation. We don't code the related signs and symptoms as additional diagnosis. And again, this differs from the inpatient setting. Patients that are receiving therapeutic services only during an encounter or visit, we sequence first the diagnosis, condition, problem, or other reason for encounter as shown in the medical record to be chiefly responsible for the outpatient services provided during the encounter or visit. And then we code any associated conditions or chronic conditions as additional diagnoses. The only exception to that rule is when the primary reason for the admission or encounter is chemotherapy or radiation therapy, and then there's an appropriate Z code that needs to be assigned first, and then the problem or diagnosis for which the service is being performed listed after that Z code. Patients receiving preoperative evaluations only. So for patients receiving preoperative evaluations only, we sequence first a code from subcategory Z01.81, which is encounter for pre-procedural examinations, to describe the preoperative consultations. We assign a code for the condition to describe the reason for the surgery as an additional diagnosis, and then code any findings related to the preoperative evaluation. Ambulatory surgery. So for ambulatory surgery, code the diagnosis for which the surgery was performed. If the postoperative diagnosis is known to be different from the preoperative diagnosis at the time the diagnosis is confirmed, we use the postoperative diagnosis because it's more definitive. You know, sometimes when a provider is performing surgery and they go in, they wind up finding out that something maybe is infected that they didn't realize, or perforated that they didn't realize, and then they have a postoperative diagnosis that's different than the preoperative diagnosis because after they performed the surgery, they realized there was something more specific or more involved or something additional that was going on. So they have a different post-operative diagnosis. So we code based off of the post-operative diagnosis. See section 1C15 for our outpatient prenatal visit requirements. So encounter for general medical examinations with abnormal findings. So I talked about those ZOO codes. So the subcategories for encounters for general medical examinations, which are ZOO.0 and routine child health examinations, ZOO.12, those provide codes for with or without abnormal findings. So there's codes for with, codes for without. And if we go through that medical examination and we find an abnormal finding, like a lump in the breast, then we code for the one that has the abnormal findings. We don't code for the one without. It's because we found something. We found that the patient had a lump or something, and then that's an abnormal finding. An examination with abnormal findings refers to a condition or diagnosis that is newly identified or change in severity of a chronic condition, such as uncontrolled hypertension and acute exacerbation of COPD, and that happens during their routine physical examination. So they go in for their routine physical, they find something. A secondary code for the abnormal finding should also be coded. So we have the code that says we found an abnormal finding, and then the code for what was that abnormal finding, the lump in the breast, or what have you. Encounters for health screening, see section 1C21. And then we have the appendices. I'm not going to actually go over the appendices on the present on admission reporting guidelines. I'm actually going to finish up there. I will see you guys back with more ICD-10-CM guidelines in 2022 for the updates that I'll be covering then. All right, I hope you found this video helpful. If you did, I'd really appreciate it if you support me and the channel by giving it a big thumbs up. Don't forget to subscribe and hit that notification bell so that you will get alerts when I post new episodes. I will see you in the next episode, and until then, just keep on coding on.